to the third lecture. I have the honor to present Professor Wissam Ismail. She talked about AKI out of the box.
امبارح الدكتور رشاد يا وسام جاب سيرتك وقال ان من المحاضره بتاعته ان المفروض انت يبقى عندك روتين الكترو مايكروسكوب، يبقى عندك روتين الكترو مايكروسكوب
عشان لايت تشينز. لا روتين كابا ولاندا يمكن.
روتين الكترو مايكروسكوب.
اوكي. Well, we have اطلبوه بس انا we do have routine electron
by you.
بس هو الدكتور صلاح يدفع بعدين. Okay, and good morning everyone. And it's always a pleasure with something we look forward every year to attend Nafro Alex. And we thank all the Alexandria team from the Alexandria University for making this meeting quite special and something interesting. Thank you طبعا for the organizers and the chairpersons, both physical and virtual. And thank you very much, Yasser, and the very interesting discussion which had just went on in the last presentation, because it furnished what I'm going to talk to you today, that as Professor Hussein said, that we need maybe to change the culture with regard or we look for our patients in acute kidney injury. And of course, you know this slide much better than me. And you know that when we consider AKI, that if it's an intrinsic cause, then you consider whether it's a tubular cell injury, what you call tubular necrosis, acute interstitial nephritis, or acute glomerulonephritis. So actually, when a patient presents with an AKI or a serious rise in serum creatinine, whatever way you want to put it, you consider, is it an acute tubular injury, what you call a tubular necrosis? Is it an acute tubular interstitial nephritis, and most probably drug-induced, or it's a crescentic / rapidly progressive GN? Do you guys consider anything else? Usually, these are the main differential diagnoses you have in mind. So today, I'm just going to show you a bit of examples that maybe that when we regard AKI, we need to think out of this box and out of these three initial diagnoses. This was a 33-year-old female who presented with a serum creatinine from 1.2. She had a proteinuria around 1 gram, not sharply 1. She had no history of hypertension or diabetes, immune profile normal, no virology. She only had a history of cholecystectomy 1 month prior to presentation and reported non-steroidal use, and the clinical diagnosis with acute interstitial nephritis, drug-induced. Patient did not improve, and so she got biopsied. Now look at this. I don't know if there is a pointer here or it works. Anyhow, this is what we call granulomatous. You have a cortex with a lot of granulomas. Thank you. And these granulomas are actually, they have also giant cells, and you see that the blood vessels are fine. So this was a good biopsy. Her Congo-Red was negative. All her immunostudies were negative. So the diagnosis came as a granulomatous tubular interstitial nephritis. And the question is, what did you add? So probably this is also a drug-induced granulomatous interstitial nephritis. So what did you tell us? Why did we biopsy in this case? I knew from the beginning that this was a drug-induced. First, you knew that this is a granulomatous form and not an acute form, and that your patient is probably not going to resolve, at least not easily. Secondly, this patient was actually investigated for the differential diagnosis of a granulomatous TIN. And believe it or not, she did not turn to be drug-induced. She actually had hilar lymphadenopathy, had a magic response to steroids, and this patient was sarcoid. She had a clinical diagnosis of sarcoidosis. Sarcoidosis usually is almost never an isolated renal involvement. It is a diagnosis of exclusion. We would have never been able to diagnose her if she wasn't biopsied. This was a 27-year-old male who presented with hypertension, nephrotic syndrome, microscopic hematuria, and a serum creat of 2.3. Again, immune profile normal, virology negative, but his serum phospholipase was positive with a high titer. Fine. So this was a patient which was diagnosed as membranous, fair enough, but with no clear explanation of his AKI. His initial nephrologist attributed it to chronic changes due to the membranous, which the patient had. But then when his creatinine did not improve, actually continued to rise, he changed the nephrologist, and the second nephrologist decided to biopsy. Do you agree on this biopsy? More or less. Okay, so let's see. Indeed, the patient did have a membranous, and indeed his membranous was starting to be a bit of chronic changes. He did have segmental sclerosis and periglomerular fibrosis and a very advanced membranous. His immuno was positive for a full membranous profile. His phospholipase was positive, as you can see here, also in the tissue as well as in the serum, and his kappa and lambda were negative. Still, this did not say why his serum creatinine was. He had only an interstitial fibrosis of 30%, doesn't really explain a serum creat of 3. And I want you to look at this, and this is his one glomerulus with membranous, this is the other glomerulus with thrombotic microangiopathy. When I returned to the nephrologist, he did admit that this patient was hypertensive, usually had bouts of uncontrolled hypertension. He was completely non-compliant on his treatment, whether for the membranous or for the hypertension. And so, look, he had another glomerulus with TMA as well, and look at a nice thrombus in his arteriole with red cell fragmentation. So this patient had thrombotic microangiopathy together with the membranous. Whether it was related to the hypertension, was it related to any other cause, this was the cause of his renal injury and why his serum creatinine was rising, and probably he was going to deteriorate more if these changes turned to chronic. This was a 49-year-old male. He was non-hypertensive for over 7 years, controlled on RAS, who presented with slowly progressive rise in serum creatinine, 1.9 from 1.1 over the last 8 months. And his protein creat ratio was 1.6 grams. His virology, again, negative, nothing in the immuno, and he had no hematuria. So, again, this was a debatable biopsy. Should we biopsy this patient? He's a known hypertensive, probably has some form of FSGS or focal glomerular sclerosis. His creatinine it's a progressive rise, but still it's a significant rise if we consider it the first stage of AKI. And not to get too long, this was his biopsy. He did have a lesion of FSGS, but did not represent in the picture. But he did have a significant and a bit strange tubular injury. So these were the tubules. He had a lot of costs, but his tubules actually looked a bit odd. Too much eosinophilic. Let me get you a higher power. And these substances which you see here, I don't know, it's not the laser. Okay, I lose the R. These substances are not inside the tubular lumen. These are inside the tubular epithelial cells. You see again, here again, you see the tubular epithelial cells are swollen and looks like they have something inside of them. Here they started to crystallize a bit, and then with the trichrome, you can see that you do really have crystals, like here and there. And with EM, to favor Professor Salah and Professor Rashad, yesterday, you can see that, thank you. You can see all of these are these nice black crystals. These are actually light chain crystals. This biopsy was positive for kappa, and this is what we call light chain proximal tubulopathy, and this patient had multiple myeloma. His bone marrow was positive for 15% plasma cell infiltrate. This entity is known to be, yes, it's uncommon, but it's not rare, and it is classically characterized by slowly progressive deterioration of renal function, usually in patients with chronic or associated systemic diseases, and they go unnoticed for years. The point is that 50% of these patients only meet the criteria for smoldering myeloma, means that other 50% of these patients start only as a light chain disease or an MGRS, and if you really can't diagnose them early on, they are not going to develop into a full-blown multiple myeloma. Well, we're in a COVID era, so I would like to finalize with some COVID cases. And I'm not going, of course, touch on anything pathogenesis. I know Hussein Fishawi is going to talk definitely quite impressively about it tomorrow. This is a 34-year-old female who had no relevant medical history. She presented 3 weeks prior with severe diarrhea, prior to biopsy, I mean, with severe diarrhea, which was COVID-19 positive, and then she got complicated by an acute kidney injury. Her serum creat was 8, albumin creat ratio 75. She did not have any form of renal disease. She reported a short history of non-steroidal abuse prior to her illness, autoimmune profile normal, and virology negative. How many of you biopsy COVID patients with AKI? Oh my God, okay. Yeah, that's why we will never know anything about COVID. So, she indeed did have a tubular injury, but look what's inside the tubules. She did have these very nice oxalate crystals. Again, oxalate crystals here surrounded by a reaction, and this is how oxalates looks like under polarized light. This is a 32-year-old patient. She's definitely not a primary hyperoxaluria. So this is an acute tubular injury with oxalates. Again, what did you add? We knew that this was an acute tubular injury. No, we added a lot. First, acute tubular injury with oxalates in this age is probably iatrogenic. And within this context, you need to be very careful of vitamin C, because then this excessive intake of vitamin C in COVID patients actually do cause this type of tubular injury. And the problem with these patients is that they take a very long time to resolve. This is not your classic ATI, which is going to resolve by time. You need to be very patient. You need to do what you do and treat them as a patient. And some of them actually, their injury persists for months. So be careful that this is the whole meaning of adding this term oxalates to the biopsy, because you know that this patient is not going to resolve that quickly. Some which are henna induced or in females, especially in young females, or drug-induced, or these things, sometimes they also cause these oxalate crystals, but they're not that frank type of oxalosis. They resolve earlier. But again, you're not your regular acute tubular injury patient, which is going to resolve. So this patient did really had a problem with her vitamin C. Now this is my last case. This is a 63-year-old male who had no previous medical history. He contracted COVID-19 1 month prior to presentation, which got complicated by a non-oliguric AKI. Patient was hospitalized with a serum creatinine in one of the major hospitals in Cairo with a serum creatinine 6.8. That gradually dropped over the past month, over the month of the presentation prior to the biopsy, to 3.2. He was given a steroid protocol, upon which he was withdrawn gradually, and creatinine landed to 3.2. He had an albumin creat ratio of 166 milligram when the problem started, and then at the time of the biopsy, it was 68, so absolutely no proteinuria. Bearing in mind that this patient, in spite of his age, is not diabetic, is not hypertensive repetitively. His creatinine was normal 6 months before the COVID-19 attack. He has no history of non-steroidal intake whatsoever, and his COVID PCR prior to the biopsy was negative. Okay, I'm not going to get into discussions, but I want to show you the biopsy and show you that this patient was treated as an AKI COVID-related injury for more than 1 month. And this was his biopsy. Again, a tubular injury, but look what's inside the tubules. You have significant costs, and these are not fractured, these are even fragmented costs. And these costs actually are needle-like costs, like the ones we've seen in the tubules within the electron microscopy. They were surrounded by florid cellular reaction. This is the straightforward pathognomonic light chain caused nephropathy, and it was even positive for kappa, and sometimes this happens if it's an acute patient. His EM was actually, as you can see, very nice glomeruli, absolutely no glomerular disease, no chronic changes of any form, and his bone marrow showed a plasma cell dyscrasia. He had plasma cells up to 22%. So this patient did not have any relation to COVID, and I have more of these, by the way. I have more and more of these patients with COVID, between quotations, AKI. So, coming back to AKI and the acute tubular injury, the acute tubular interstitial nephritis, and the crescentic GN, RPGN, I just wanted to show you about these cases, that not because we think we know what is going on means that we really know what is going on. Even if your clinical diagnosis is close to the process, you still don't know what is really going on or what's happening within your patient. And I'm going to spend the last 2 minutes discussing this issue specifically towards tubulointerstitial element of the AKI, as this is more of the concern and this is more of what we see. And when you biopsy, the first question you want it to be answered is whether this is an acute tubular injury or an acute interstitial nephritis. And I want to tell you that an acute interstitial nephritis does resolve by time and leaves a residual element of tubular injury and a mild inflammatory infiltrate. And on the other hand, an acute tubular injury by time can develop a mild inflammatory infiltrate and interstitial edema. And you can get caught at a certain stage in the biopsy between that you really don't know, was this an acute interstitial nephritis which is resolving, or is it an acute tubular injury which is getting worse because it's developing inflammatory infiltrate and edema. The second question, is this an acute or chronic patient? Do we develop an AKI, does he have an AKI over a CKD or not? The extent of acute to chronic damage varies. By the way, your patient could have started acute, and then we have chronic changes now in the biopsy because you've been treating him for more than 1 month now, and there is no response because we did not know what was going on. So it is valid to see some chronic changes, and then it's really difficult to evaluate whether this was what was present in the beginning or it was a result of the recent AKI. One of my favorites is it drug-induced, whether the tubular injury or the interstitial nephritis. Yes, we do have signs which can say that this is probably iatrogenic. And iatrogenic covers a lot of things: herbs, other drugs than non-steroidals, and a topical use, and things you would never consider, even hair treatments. And all of this can actually cause the same type of insult. My point is that if you have an infiltrate, yes, it can provide a clue to the underlying etiology. But bear in mind that, yes, if I have a lot of neutrophils, then this is probably infectious. But eosinophils, for example, are a non-specific cell. It does not equal drug-induced. It can be vasculitis. You get to get a more eosinophil-rich infiltrate in vasculitic patients than in drug-induced patients. And you can get it completely non-specific, like in diabetic patients. It doesn't mean anything. So not every patient who has eosinophils in urine has an interstitial nephritis with drug-induced or even in the biopsy. So you need to also consider this. And was this patient crescentic? If the problem was actually glomerular, and I want you to look at the biopsy and tell me how on earth can we tell whether this patient was crescentic or not. Patients with small vessel vasculitis or crescentic GN can get to this stage in 2 weeks, in just 2 weeks. So it's the timing of the biopsy. If you're going to take a biopsy, take it early. If you want any of these questions to be answered, and they are why you're taking the biopsy, then take it early so we can answer these questions for you. Otherwise, it's not that easy. We consider acute tubular injury and acute tubular interstitial diseases more or less within the same disease spectrum because tubules and interstitium are considered as one entity. And we do have a wide variety of renal and systemic diseases, and that this is the main compartment which correlates with the renal function. So not every RPGN is actually an RPGN, or not every AKI is an RPGN. And look at the list of the tubular interstitial diseases with their primary and secondary. And yes, more than 50% of these diseases are going to present as an AKI because the slow rise of serum creatinine before the acute decline is actually undetectable and patients do not sense it. So from our point of view, this is going to be presenting as an AKI with or without anemia, which again does not have to be anemia related to acute kidney injury. And in relation to fibrosis, even if we know these regular patients with acute tubular injury and with interstitial nephritis, get to know that by time, any presence of inflammatory cells is going to start a process of fibrogenesis, and that this is the interaction with the extracellular matrix. And as you can see, you have edema, inflammation, and very early fibrosis and fibroblasts. So whatever the process is, you're going to develop fibrogenesis. So it have been a time during the last 6 or 8 years that it's time for a new concepts in regarding AKI, new definitions, and that we need to know that acute and chronic kidney injury are not really separate entities, and that these diseases, both these syndromes, are actually interconnected syndromes, can lead to each other, can precipitate each other, and even tubular interstitial disease can precipitate glomerular disease. We know very little about TIN. We have very few biopsies in tubular interstitial disease and even fewer biopsies in acute kidney injury. Remember that clinical and laboratory data alone is not enough. Most of these diseases can be successfully treated, and you're preventing your patient from at least minimal scarring in the kidney, and that untreated acute TIN can result in interstitial fibrosis and irreversible renal injury, even if your patient's creatinine improved. Thank you very much.
Thank you, Professor Wissam, for this a very nice presentation.
Thank you, Dr. Iman.
She opened our mind to another explanation for AKI. Any questions?
Thank you, Professor Wissam. You have seen some patients got COVID-19. I'm asking you directly, have you seen ever in this era what our Professor Rashad Barsoum stated, COVID nephropathy and collapsed glomeruli due to COVID?
I haven't seen in the patients that I received the biopsies. No. But from our very small scale of biopsies, actually. I was really surprised because I was expecting that we're going to get more biopsies of these patients because this is something new and we want to know what is going on. But I have to say I was disappointed that the nephrology community dealt with the AKI COVID-related as they deal with any form of AKI, especially when patients improved. So no, in the biopsy cohort that we've seen, and I have to say that it's quite small, I haven't seen any collapsing glomerulopathy, neither in transplant or native biopsies, but it's been reported in the literature.
Yes, thank you.
Can I ask Professor Salah? Thank you very much for this elegant presentation. I enjoy it very much. الحقيقة it's marvelous. Congratulations, Sam. I have some query about the COVID cases that you got their biopsies. Look, you to share me the clinical scenario of such patients. Most of those patients are on anticoagulant because of the thromboembolic manifestation common in those patients. So this is number one. Number two, the milieu and the scenario, the clinical scenario where the patient is present in a very hectic environment in ICU sometimes, and all the surgeons are in panic because they are caring of such highly infectious patients. So the biopsy is not so easy to get in such patients. Yani. But back,
of course, and
yes.
I know most patients also resolve quickly, and it's a mild AKI. So.
I would like to ask about the last case you present, the plasma cell dyscrasias. There is a coincidence for the two scenario? Can COVID by the dehydration or something like that can elevate the presentation of such of the plasma cell dyscrasias, or what is your suggestion?
Well, what I've seen with the COVID patients, and again, very small cohort of patients, so very limited experience. But yes, it seems that the cytokine storm of the COVID or whatever happens actually reveals an underlying disease in the patient, and we've seen this in the biopsies. So I think yes, that probably the myeloma and the cause nephropathy was precipitated by the COVID infection, maybe or maybe not.
Oh. Hmm.
But it's a
If there is,
possibility.
okay, if I would like to ask you, have a follow-up with a COVID patient in the convalescence period, and he has some renal changes like proteinuria. Would you advise to biopsy those patients? Are you optimistic to find something in their renal biopsies?
It depends on the level of the proteinuria, and if it's a significant proteinuria, or if it's a proteinuria which is enough for an indication of a biopsy, or if it's progressive, then yes, I think you need to biopsy. COVID or not, you need to biopsy. So because we don't really have anything linking, we don't have serious, reliable literature to date which proves any form of a direct viral COVID effect on the kidney. And nobody could isolate the virus in the kidney. We couldn't stain for it. The pictures which shown, the papers which were published with the EM pictures of the virus are extremely debatable, and probably this is not the virus itself. So we don't have any solid evidence which says that we do have a direct effect of the COVID on the kidney, as per that it's directly causing, so everything is indirect. So yes, we don't know why you need to biopsy the patient if the proteinuria is enough for a biopsy. Dr. Muhammad?
Thank you.
Thank you, Professor Wissam. Elegant as usual. These cases elegantly give us an attention about the vital role of the biopsy sometimes as a life-saving. You diagnose the patients with multiple myeloma, a patient might start life-saving treatment, and also at the same time, it might protect the patient from unnecessary immunosuppression. So the biopsy, in certain condition, it might be life-saving. It might protect the patient from unnecessary immunosuppression. So we have to be free-hand, and if we cannot explain the clinical scenario of proteinuria, hematuria, which sometimes might be misleading, we think patient is in remission, in relapse, but he is in remission. He is in relapse, but he is in remission. Sometimes the clinical finding or the unit finding give us a false clue, especially in membranous. For that, going to the biopsy and to be free-handed to do for any situation without a clear explanation of the rising creatinine, I think it is very important to be in mind of all the nephrologists about the role of biopsy in certain conditions.
Thank you.
Thank you very much,
Thank
Professor
you very
Wissam.
much. Thank you.